Hello.
Hi, Bree.
Abby, did you see that package that was at the door? Yeah.
Yes, I did. Thank you.
Hey, Weidi.
Let's give it one more minute. This is a different time than we normally have scheduled, so we might have a couple people coming in a little late. Alrighty, welcome everybody. Thanks for joining us for the final seminar of the semester. I just wanted to quickly highlight that I sent out an email earlier this morning asking for any new presentations, grants, publications, anything like that that you would like to share with CSEF and with our affiliates. So if you have anything you'd like to share, and this is for faculty, students, staff, postdocs, please respond there. And with that, we'll turn it over to Whitney.
Yeah, thank you, Abby. And also thank you for the opportunity to share my research with the group. I'm going to share my slide. So today, the presentation will be a practice talk for my accepted oral paper presentation at SWOR next year. And I really appreciate this opportunity. So first, a little bit about my background. My name is Weidi Qin. I'm a postdoc at the Population Studies Center at ISR with the University of Michigan. My research has focused on diabetes management and the mental health and psychosocial coping resources of this condition. So today's presentation was also one study from my dissertation. The topic is health behavior changes after diagnosis of diabetes among middle-aged and older adults. So here's the outline for my research today. I'm going to give a little bit background, theoretical framework and research question, and then I'm going to share my findings and conclusions. So a little bit background, why is diabetes an issue among older adults, middle-aged and older adults? So here's a table. As we can see that older adults typically defined as those 65 years and older have the highest prevalence of diabetes. And also for the middle-aged adults, as we can see that they have the highest incidence of diabetes. So in many situations that individuals who have a diabetes in late adulthood are usually carried this condition from their middle adulthood. So that's why I often study middle-aged and the older adults together for diabetes. So having diabetes is associated with many negative psychosocial and health conditions. And here's a list. such as cardiovascular disease, vision issues, and kidney issues, and also mental health, depression, because routine management of diabetes requires like check blood level, blood sugar level, and also taking oral medication. So all these activities can be associated with depression, anxiety, which can also be related to lower quality of life. So another issue with the diabetes is that it is expensive. So in the United States, more than 60% of the total healthcare expenditures on the condition were spent on older adults. So they are the most vulnerable population to this condition and more likely to be affected by the adverse influences of this condition. So that's why I'm focusing on diabetes on this population. So the high prevalence and the incidence of diabetes in this population highlight the importance of health behaviors and the utilization of preventive care services. So one thing about diabetes is that it is highly responsive to health behavior management. So it is different from diseases like cancer or arthritis, that the long-term progression of the disease is unpredictable and usually not so responsive to health behaviors. And however, it's also different from conditions like hypertension, which is easier to manage through routine health behavior management and intervention. So diabetes lies in the middle of this series of chronic condition, which is also make it the most interesting condition to me. So for the health behaviors, there are typically two domains. So one is the health risking behaviors. So these are the behaviors that can undermine a person's health status, such as individual excessive drinking and smoking. So the goal for these types of behaviors is to reduce and eliminate the engagement in these behaviors. There's also another set of behaviors are health promoting, so such as physical activity, healthy diets, and these activities are shown to improve individuals' health. And the goal is to increase individuals' engagement in these type of behaviors. Another set of focus on my study is the utilization of preventive care services. So these are the services that are used to detect or prevent any medical conditions, such as flu shot, getting flu shot so people can be immune to certain viruses and avoid getting common cold and the flu disease. And also blood glucose check, which is also important for diabetes management. They need to check their glucose from day to day to make sure it maintains a certain level, and also cancer screening. So my study focused on these two sets of outcomes, the health behaviors and preventive care services. So the present study was guided by the teachable moment model. And here's a diagram showing how this model explains the relationship. So usually it starts from a queuing event. And in my study, it is a diagnosis of diabetes. So immediately after getting a diagnosis, which serves as a queuing event, it can trigger strong emotional reactions among individuals, such as a fear of death and also increased perception of the risk. So the example is, once after a diagnosis, individuals may start to reflect on their unhealthy behaviors and realize that, yeah, now it is time to make some changes because of these strong reactions to this particular point. Like the diagnosis can be a turning point and motivate individuals to think about their behaviors and initiate healthy behaviors. So after the queuing event, individuals can go through a series of emotional and a cognitive process that they are going to more consciously learn about what is healthy behaviors and try to mobilize psychosocial resources, which eventually is expected to lead to initiation and the adoption of healthy behaviors following the diagnosis. So in the existing literature review, there are some mixed findings about health behavior changes after a diabetes diagnosis. So the findings of changes in drinking and the physical activity have been inconsistent. So like, for example, some studies find that individuals had reported no changes in alcohol consumption or even increased alcohol consumption following a diagnosis, and the similar patterns for physical activity. The discrepancy in the findings could be due to the sample differences in the sample characteristics. So for example, the study found increased drinking following a diagnosis were conducted among a clinically based study participants, versus there are some other studies used community-based participants. So these individual and sample characteristics differences may explain the discrepancy in the findings. But however, I did find consistent evidence about changes in smoking after the diagnosis. So in general, individuals, they reduced and or ceased smoking following a diagnosis. And there are very limited evidence about the changes in utilization of preventive care services after diagnosis. Given that the utilization of these services are very important to diabetes management, especially things like flu shot or blood cholesterol check, which is very relevant. So I'm also interested to explore these outcomes. So based on the theory model and the literature review, this is my research question. So particularly, I want to explore whether middle-aged and older adults engage in health behavior changes and the change in utilization of preventive care services after a diabetes diagnosis. In order to achieve the study aim, I used the data from the Health and Retirement Study. It is a longitudinal panel study among national representative of older adults, middle-aged and older adults aged 50 years and older. So this study was surveyed every 2 years, and individuals are followed up like a panel study every 2 years. So for the selection criteria, I used non-proxy respondents from 6 waves from 2006 to 2016. The reason for choosing these particular waves are because the biomarker data were available since 2006. So I was able to check the self-reported diagnosis versus the A1C level to see whether they are accurate. And also I excluded individuals who had a diabetes at a baseline. So I was able to calculate the incidence of diabetes diagnosis throughout the study waves. So the sample exclusion resulted in a sample size of about 17,000 individuals. So here's a list of the sample characteristics. So they are about 64 years old, and the majority were female, and the majority were non-Hispanic white, and about 12% developed diabetes throughout the study waves. So another strength of HRS is that it also provides the sampling weights and design factors, which allow me to adjust for the complex sampling design and generate population estimates. So in terms of the outcome variables, so for health behaviors, I have 3 outcomes. The first is alcohol consumption. So I dichotomized this measure into excessive drinking versus no or moderate drinking. And this dichotomization was based on the USDA dietary guidelines for Americans. So particularly, no or moderate drinking were defined as 2 or less drinks for men and 1 or less drink per day for women. And this criteria was also recommended for older adults and individuals with diabetes by American Diabetes Association. So for smoking, I also use the binary outcome measure with they are current smoker versus non-current smokers. And also for physical activity, I dichotomized it based on the recommendation guideline from the DHHS, Physical Guidelines for Americans. So the definition was for being physically active is individuals should get moderate to rigorous level activity 2 or more times per week. So this is how I dichotomized these outcomes. And for the utilization of preventive care services, I have 4 services focused, which are blood tests for cholesterol and influenza vaccination. So these are very important. So especially given the current context of COVID-19, individuals with diabetes tend to have more adverse health complications from flu versus the normal population. So getting flu is extremely important for older adults with diabetes. And I also included a prostate cancer exam for men and a mammogram for women. And again, the response categories were binary yes or no. So for the predictor variable, I used the self-reported physician diagnosed diabetes, and it is a yes or no with a binary outcome. Because I excluded those who had a diabetes at baseline, so this measure was used to calculate the incidence, the onsets of a diabetes diagnosis. So here are my control variables. So I controlled the baseline variables through the study period. So I included demographics, socioeconomic status, and health indicators that include disability, functional health, and the mental health. So for my analysis strategy, I used a case control difference in differences approach. So for my study, the case group are those who developed a diagnosis of diabetes throughout the study waves. And for control group are those without diabetes throughout all the waves. I individually defined the pre-diagnosis and the post-diagnosis periods. So pre-diagnosis was defined from the starting wave till before the wave that the respondent first report a diagnosis. And the post-diagnosis period was defined as the first wave when a participant reported a diagnosis and all the following waves. So I used the one-to-one match without replacement using the nearest neighbor matching. So this would allow me to generate a balanced sample. So the matching variables are study cohort and the number of study waves. And after matching, I assigned the same pre and the post-diagnosis periods to the control group and assigned the same periods with their matched cases. And the assumption of the DID approach is that, so for individuals who developed a diagnosis of diabetes, if they haven't developed this condition, then the trend in behavior changes should be the same as those in the control groups. So by applying this approach, I am able to netting out the other factors that contributing to behavior changes. And so I can estimate the net effects of a diagnosis on behavior changes. So after matching, I used the weighted logistic regressions to estimate the effects of diagnosis on health behavior changes. And this is the function that I used that can be used to express the models. I applied the sampling weights and the strata under the cluster. So first, for the results, here are the bivariate results here. As we can see, before and after the diagnosis, there are significant changes for all the health behaviors and the 3 preventive care services. So in particular, so basically after the diagnosis, individuals changed from excessive drinking to moderate drinking, ceased smoking, and surprisingly increased the physical inactivity or become more physically inactive. And also there is an increase in the utilization of blood tests for cholesterol, flu shot, and prostate cancer screening. So these are the bivariate relationships. However, in the fully adjusted models that controlled for social demographics and health factors, I found that only the net effects of diagnosis was found on 3 outcomes. So the excessive drinking, a blood check for cholesterol, and a flu shot. So because the interpretation of the interactions is a bit difficult, so I calculated the difference in probability to facilitate the interpretation. So specifically, 45 per 1,000 individuals changed from excessive drinking to moderate drinking following a diagnosis. And another 2 significant findings are for cholesterol check and a flu shot. So again, 65 per 1,000 individuals, who did not utilize check their blood test for cholesterol, checked their cholesterol following the diagnosis, and so is for flu shot. So based on my findings, I have a few conclusions. So the first is that middle-aged and older adults who engage in excessive drinking substantially reduce the drinking amount after the diagnosis. So this finding lends support to the argument of the teachable moment, that a diagnosis of diabetes may be a teachable moment in influencing the drinking behavior. So particularly following a diagnosis, individuals may have strong emotional responses and prompt the survival instinct, such as the fear of death, and they will start to reflect on the drinking behavior. And they may also think about modify the perceived norms of drinking. So sometimes when people go outside, meet friends in a social setting, it may be inevitable to involve some social drinking. But after the diagnosis, individual may modify their norms of drinking in these social settings. So all these cognitive process and the emotional process may lead to individuals' reduction and the cessation of drinking following a diagnosis. So my my findings in smoking and the physical activity were not significant in the fully adjusted model, but they were significant at the bivariate levels. So the possible explanations are that the net effects of a diabetes diagnosis may not be salient in influencing behavior changes in smoking and physical activity. So there might be other reasons of maturation that can explain the finding. So for example, as individuals getting older, and the advanced age may be associated with more disability, frailty, and some physical changes and cognitive changes. And these can be barriers to individuals' access and engagement in physical activity. And it is also possible that some other factors influence the individual's reduction in drinking as they age. So my study did not lend on the findings on smoking and physical activity did not lend the evidence to TM models, but pointed to some other factors that may influence the changes in these behaviors. And my third conclusion is that middle-aged and older adults, they increased the utilization of cholesterol check and the flu shot after the diagnosis, but I did not find changes in the cancer screening. So the explanations are that checking cholesterol and getting flu shots might be more relevant to diabetes management. So doctors and physicians, they are more likely to recommend checking cholesterol and getting flu shot among individuals with the diabetes. So the findings on prostate cancer and the mammography, it's not surprising to me because I read that some studies showing prostate cancer exam, because of the way they conduct it, it can cause some psychological harm to individuals. So many doctors, they do not recommend this screening. So for these reasons, I did not have significant findings for the cancer screening utilization. So there are some limitations about my study. So the HRS, they measure the self-reported diagnosed diabetes. So this type of, so this question automatically excluded those with undiagnosed diabetes. However, this limitation is not a big issue for my study because I want to capture the teachable moment. And so I would need people to be aware of the diagnosis that can trigger the emotional response. So if individuals are not aware that they have this condition, then they would not have that emotional response. And also there's no differentiation between type 1 and type 2 diabetes in HRS. So I controlled this limitation by excluding individuals who had a diabetes at baseline. So all the sample who had a diabetes in my study developed this condition after age 50. And usually people who developed diabetes at this age are typically have a type 2 diabetes. Another limitation is that there's no data available on family history of diabetes or duration of diabetes. So these would be important to control for studying the diabetes outcomes. Another thing is the unclear temporal sequence. So because HRS were conducted every 2 years and all the questions collected at one particular wave were based on all the events in the past 2 years. So I wasn't able to identify exactly whether the diagnosis or behavior changes occurred before which one occurred first. But this is the only issue when the diagnosis and the behavior changes occurred in the same wave, but not an issue for the other conditions. So the implication for social work practice, because it's a presentation for SOAR, I focused more on social work. So we can take advantage of a teachable moment. So because following the diagnosis, older adults may have the highest motivation to engage in health behavior change. So we may be able to augment the success of behavior change and maximize the efficiency of these intervention programs by providing interventions at the time of a diagnosis. So for example, upon the diagnosis, doctors or health professionals can recommend individuals to a diabetes self-management training program at the same time. So because they have the highest motivation to change at this point, so we might be able to take advantage of the teachable moment. Another issue is we can use technology-based remote intervention, which is more important given the current context of COVID-19, when many people are, especially older people, are practicing social distancing. So we may be able to equip them with technology like iPad or smartphones, and health professionals can text reminders reminding them of health behaviors from day to day. And to help them to engage in healthy behaviors. So yeah, this is my presentation. Thank you all for your attention. And now we'll take any questions.
Thank you so much, Weidi. It was a great presentation as always. I guess I'm wondering about this, you know, the translation of this into, you know, into clinical care. And I wonder if you've thought about sort of what types of either sort of how these sorts of things are communicated, like how much of this, because I think the teachable moment is a really positive way to spin it, but there's also, of course, as you know, like the threat, and like, most, when we feel threatened, we are very avoidant. We don't want to think about doing something. We don't, and for something like diabetes, which is typically asymptomatic, or at least the symptoms are not necessarily recognized as being related to diabetes. There's a reason they call it denial of diabetes, right? Like it can often take people several years to sort of fully accept the diagnosis. And so I guess I'm wondering either and maybe this is a good thing for social work, right? Like, I mean, in terms of when we think about healthcare teams, so I don't know if you could speak to potentially what you see the role of social work is in potentially addressing this specific kind of problem, like whether this is in a, is it anyway, so it's kind of a poorly formulated question, but do you get what I'm trying to get at?
Yeah, so this is actually one chapter from my dissertation. So the other two chapters, I explored the similar topic using different approach. So so the reduction in drinking is consistent, but for physical activity, it was a little bit mixed. So another study, I found that individuals, they reduced physical activity amount following a diagnosis. So I think, yeah, there could be a mix. So the thing is, a diagnosis of a diabetes, they can serve multiple concepts. So they can be a teachable moment and trigger health behavior changes, but they can also be a stressor, a stressful health event that become like a hinder individuals' understanding of the situation and engaging in healthy behaviors. So a diagnosis of diabetes may have a different influence depending on the individuals. But for this particular study, this is what I find. But when I'm trying different approaches, I do have some differing findings on that. Yeah. And also, I thank you for mentioning about the interdisciplinary team, though. So that's important because I feel my work is very interdisciplinary, and I'm also trying to emphasize the role of a social worker in this management. Yeah.
Yeah, and I think that's a really, one of the people you might want to talk with here at Michigan is a guy named Kevin Joyner. He's a nurse in the School of Nurse, he's a nurse practitioner. But he's interested I was just at a talk that he did the other day on community health workers, in potentially helping to encourage people with pre-diabetes to get into a diabetes prevention program. But I think especially when, and you kind of started off your talk about, this is for the social work conference. And I definitely, my only piece of advice would be in terms of when you actually do the presentation, to really be very explicit about what is the role of a clinical social worker. I think it's very clear, like, why the problem matters for social work, but in terms of, and I think this is feedback that, Robert Taylor would give you too, right? But you need to be very explicit about it. So whether this is using terminology around, is there guidance from a social work, professional organization about this, right? Like to include a slide about that, like this is the role of social work, or for example, like what is the American Diabetes Association say about social work and its role in supporting psychosocial outcomes. So I would just be really explicit about it in that kind of closing slide there.
Okay. Yeah.
I say this as somebody who's given talks to people in social work and been asked, what does this have to do with social work? And I'm like, what
exactly.
Yeah. And I'm like,
and I got asked that from time to time.
Yeah. So anticipate that and address it. Yeah. But yeah, those kind of calls to authority are generally effective ways to kind of demonstrate that people that they care about what you're doing.
Mm-hmm. Thank you. Any other questions? or comments or feedback? Or any suggestions in general?
The term here, so I think it's a little folks are a little overwhelmed getting things done.
Yeah.
All right. Go ahead, Abby.
I was just gonna say thanks so much, Weidi, for presenting for us, and thank you everybody for attending. We will start up the seminar schedule in January, and have a good break, everybody.
I'll see you later today, Weidi.
Thank you, everyone.
Bye.